now invite Dr. MUDIT TYAGI for sharing his thoughts on managing infective retinitis. Dr. MUDIT is a consultant in uveitis and ocular immunology service at LV Prasad Eye Institute, Hyderabad. His areas of interest are VKH, ocular syphilis, ocular inflammations, endoscopic retinal surgery, retinal detachments, vitreoretinal surgeries in uveitic disorders. His achievements and awards: 2012, he got the best surgical video at URetina, and 2015, Uveitis Society of India Travel Grant winner for the paper Sympathetic Ophthalmia following intraocular surgeries. Honor and awards: American Society of Retina Specialists in 2016. Rhett Buckler Award for Best Surgical Video in American Society of Retina Specialists Annual Conference 2017. Senior Achievement Award, American Society of Retina Specialists 2019. And Innovation of the Year Award at Vitreoretinal Society of India Annual Conference for work on glue-assisted retinopexy and rhegmatogenous retinal detachments. I would request Dr. MUDIT to please share his screen and share his thoughts on managing infective retinitis.
All right, are my slides visible?
Yes.
Yes, sir.
Yeah. All right, thank you so much, Dr. Chekitan, for making me a part of this very nice instruction course. And thanks to AIOC for giving us this opportunity. Now, when it comes to infective retinitis, I think the treatment part is not that much of a challenge because we all know how to go ahead and treat the infections. The problem lies in correctly identifying them and identifying them early so that the treatment can be started. So there are certain clues to identifying a lot of these retinitis, what we call as a pattern recognition. And that's what I will be talking to in the next few slides. Now, the first thing for any general ophthalmologist, or for that matter, any ophthalmologist, is to first of all differentiate between whether you are dealing with a retinitis lesion or a choroiditis lesion. So how can you clinically determine it? If you see a lesion which is superficial and is obscuring the vessels, then most probably it is a retinitis. Choroiditis lesions tend to be deeper, and because they are deep, you will be able to see the vessels coursing over the lesion, like what you see over here. So like what I said again, you see this lesion, this is superficial, and in this area, the vessels are not visible. Whereas over here, you see a deeper lesion with vessels coursing over it, and that's a choroiditis lesion as compared to the superficial vessel obscuring lesion, which is a retinitis. Other common problem which can happen sometimes is to differentiate between a retinitis, choroiditis, and a scleritis. And FFA can be a very important tool in differentiating between them. So the two things which you are supposed to look at are the intensity of the early hypofluorescence and the pattern of early hyperfluorescence. So the intensity of the early hypofluorescence is maximum in retinitis, followed by choroiditis, and lastly scleritis. And the pattern of early hyperfluorescence is perilesional in retinitis, intralesional in choroiditis, and pinpoint in scleritis. And this is a clinical pearl which I owe to our teacher and mentor, Dr. Avinash Patange, who was the one who first kind of serially documented it and told it to us. So this is a learning which we got from him. So you look at this is a retinitis lesion, and you see this perilesional hyperfluorescence over here and this early hypo. Compare that to choroiditis, where the early hypo is not that significant and the lesions hyperfluorescence is not perilesional but intralesional. As compared to that, in a nodal scleritis, you see these multiple pinpoint leakages and the characteristic T sign. So combining these FFA findings, you will be able to differentiate between whether you are dealing with a retinitis or a choroiditis or a scleritis. Moving on to some clinical examples, which are common retinitis lesions which we encounter in our clinics. So toxoplasmosis usually is a retinitis. One of the most common causes of a unifocal retinitis or a retinochoroiditis is a toxoplasmosis. And you will see retinitis adjacent to a scar. If you see that, again, you should think of the fact that you are dealing either with a toxoplasma or retinochoroiditis. It usually heals with pigmentation and scarring. So primary ocular toxoplasmosis most of the times manifests as a unifocal retinochoroiditis lesion, like what I said over here. So in an immunocompetent or an immunocompromised host, there may be a frequent involvement of macula, unifocal lesions, as I said earlier. There is no consistent direction of spread, and there is associated significant inflammatory response in vitreous. So this is another case where you see this lesion which is next to a scar, a unifocal retinochoroiditis adjacent to a healed old scar. Again, this is a clue to the fact that you are dealing with a toxoplasma retinochoroiditis. CMV retinitis, on the other hand, presents with multiple hemorrhages, peripheral retinitis, areas of central clearing, arteriolar sheathing. So if you see a patient who is immunocompromised, either because of the fact that he's HIV positive or because they're on a long-term immunosuppression for any disease, and you see these multiple retinitis lesions, one of your differentials becomes the fact that you're dealing with a CMV retinitis. Another point to remember is that because these patients are immunocompromised, there will be a minimal AC reaction, as well as the fact that there will not be vitritis which is commensurate to the retinitis which you are seeing underlying. So CMV retinitis can present with its characteristic patterns. Like I said, there will be absence or minimal vitritis. You can have three common forms, either a fulminant form, or loss of vision in these cases is because of a macular involvement. You can have a granular or indolent form. And in these cases, subsequently, there's a risk of a detachment which can occur because of the ischemia and necrosis which occurs, and multiple breaks which can occur in periphery. You can have a perivascular form of what we call a frosted branch angiitis appearance. And remember, frosted branch angiitis can also be seen apart from CMV retinitis in idiopathic disease, Behçet's, sarcoidosis, lymphoma, leukemias, and rarely SLE. Rarest is a mixed form. Post-fever retinitis, your patient will give a history of past episodes of fever, usually occurs in immunocompetent hosts. There is a frequent involvement of macula or the disc. Acute retinal necrosis, another different form of retinitis, which can happen in immunocompetent host as well. You may see a moderate anterior segment reaction, but remember, sometimes you may see a dense vitritis. So the presence of a dense vitritis, two of the most common differentials are either in acute retinal necrosis or a toxoplasmosis. And this is a characteristic ARN lesion where you see these multiple retinitis lesions in the periphery with peripheral occlusive arthritis and signs of vasculitis. The third pattern to identify is a progressive outer retinal necrosis, which happens most of the times in an immunocompromised host. Again, minimal AC or vitreous inflammation because your patient is immunocompromised, has a predilection for macular area, rapid progression is noted, and you see a perivenular clearing of the retinal opacification like what you can see over here. You see a retinitis lesion with perivenular clearing, what you call a mud cracked appearance. Think of progressive outer retinal necrosis. Ocular syphilis, again a disease which we are seeing more and more in our clinics and important to identify for all of us. If you see this peripheral ground glass retinitis with these multiple miliary lesions, think of ocular syphilis as one of your differentials. And the test to be done over here is a treponemal test called TPHA, which has got a sensitivity and specificity of more than 90% in cases of ocular syphilis. So like I said, if you see this pattern of multiple miliary lesions, and if an OCT shows full thickness spread of these lesions, again, characteristic sign of ocular syphilis. So these are the three forms which I described. And this is the fourth form, which is the characteristic placoid chorioretinitis, which is seen in ocular syphilis. Another common disease which can be identified by its pattern is Candida Endoscelomitis. And this is a characteristic OCT feature which has been described as a rain cloud appearance on OCT. And I'll just show you an image of a patient. Let me skip the OCTs over here. Yeah, so this is another patient of ours. This is a lady who presented to us 2 weeks after having undergone a hysterectomy, and she had these two lesions over the macula in the right eye as well as the left eye, and you can see this cloudy appearance of this retinitis lesion. And the OCT of the right eye shows subretinal lesion over here, whereas if you go to the left eye, you see this characteristic rain cloud sort of an appearance on an OCT. And again, this is a image and a characteristic pattern which points heavily towards the fact that you might be dealing with a Candida. I will just stop with this. So like I said, I will stop over here in the interest of time.
Please continue. We have time. Not issue.
I can? Oh, all right. Thank you so much. All right. So let me just go back to this. The last pattern which I want to talk about is if you see a patient with unilateral lesions, with these multiple lesions which are there, which may sometimes disappear over a period of time, you may be dealing with a diffuse unilateral subacute neuroretinitis. So these are patterns which can be easily discerned. I would skip this case, but again, this was a patient who was initially thought of as a viral retinitis. But if you look carefully, you have got this unifocal retinitis with additions of vitreous over here, and this was a patient of toxoplasma. Similarly, another patient over here was initially thought of as ARN, but if you look at it carefully and identify and apply the patterns which I just described, you see this retinitis lesion over here and an adjacent scar. And this was again a patient who had an atypical toxoplasma retinitis. Post-treatment with clindamycin and subsequent Bactrim DS, the lesions regressed, and you can see this healing lesion over here. So the point is that pattern recognition can be a valuable tool in identifying these cases of infective retinitis. And that is the most important part. Once you know what is the type of infection you are dealing with, the treatment becomes easy. You just need to apply the proper antimicrobial agents. And with that, I will stop my presentation. Thank you so much for
Thank you.
this.